I just want to welcome everyone here today. We're going to get started with our collaborative on chronic kidney disease. And today the session will be focusing on identifying patients at risk for the development and progression of chronic kidney disease. And to start with, we just kind of want to welcome everybody, find out who's all here on our session today. We are expecting a few more people to join us. I know people's schedules are quite busy, so we might be having a few people join us as we progress through the session today. And I just like to ask everyone to share their name, their title, which clinic or organization you're with and where you're located, and then why you're interested in participating in this collaborative. And so I'll start. My name is Jerry Henniker, and I'm a program manager at Stratus Health. Stratus Health is a partner in the Superior Health Quality Alliance, and I am also a registered nurse. And I am located in Minnesota in the Twin Cities area. I actually live in a small suburb outside Minnesota, the Twin Cities, but basically Twin Cities area. And I'm interested and wanted to be part of the work that we're doing on this collaborative. Is I actually have, my father had kidney disease and was on dialysis. His kidney disease was due to hypertension. Then I also have a sister who has polycystic kidney disease. And as we'll learn about GFRs today, her GFR is, not the best either. So that was why I was interested in being part of this collaborative. And I'm going to turn it over, and I'll just call on everybody. I'll kind of go down the line to do introductions. So Rachel, would you like to introduce yourself next?
Sure. Thanks, Jerry. Hi, everybody. I'm Rachel Bender. I'm a physician assistant with Midwest Kidney, working with Superior Health. And I also work in nephrology at University of Michigan in Ann Arbor, Michigan. I've worked for several years in our multidisciplinary CKD clinic, which we started at U of M in 2013. And I've also been working in chronic outpatient hemodialysis for about 16 years. Working in CKD clinic and chronic hemodialysis has really informed me how there's a lot of room for improvement. For not only identifying and treating CKD earlier, but also how we communicate kidney disease to our patients and how we can be better at doing this. And that's really kind of what brought me to participating in this kind of work.
Thanks, Rachel. Dr. Campbell, would you like to introduce yourself next?
Thank you, Jerry. I'm Orville Campbell. I'm a nephrologist by training. I am currently serving as the Vice President for Strategy and New Business Development for MPRO, the Michigan Peer Review Organization. I'm happy to have been invited to be a part of this important work. I can't imagine more impactful work in the present time, not just because of the cost of this disease, but because of the associated mortality and morbidity with the disease. I think it's perhaps touched everyone's life that's on this call today. So thank you for the invite. And I look forward to participating and hearing. There is no market on knowledge by any one person, so I'm happy to be a part of the team. Thank you.
Thank you, Dr. Campbell. Mary, would you like to go next?
Hi, everyone. My name is Mary Funseth. I am a quality improvement advisor for Superior Health. And I'm so thankful to get to also be a part of this team today. I'm also part of an organization from Wisconsin, which is a partner within Superior Health. Our organization's name is Metastar. And I am definitely interested in this topic area. I am a social worker and have worked in both the community and in long-term care, knowing a great number of people, unfortunately, who had kidney disease. And so I I'm learning lots by getting the information from the experts here, there in the room, and I'll look forward to hearing even more.
Thanks, Mary. Diane Carlson, would you like to go next?
Yes. Good afternoon. My name is Diane Carlson. I'm Executive Director of Midwest Kidney Network. We are a joint venture partner of Superior Health and extraordinarily proud to be involved with this work. With the Midwest Kidney Network, our contract with the Centers for Medicare and Medicaid requires us to be working with people once they've started dialysis or become a kidney transplant recipient. And career long, I've always wanted to start earlier. So thank you for everyone being on this call to work together to help to slow the progression of kidney disease for those people who might not need dialysis or transplant later in their lives, or if they do, they go in with a softer landing. Thank you in advance for all the work that you'll be doing.
Thanks, Diane. Janelle, would you like to go next? Janelle Gagne? I'm not sure, Janelle, we're not hearing you if you unmuted, so.
Can you hear me now?
Can hear you now.
Oh, perfect. Okay, sorry about that. My name's Janelle Gagne. I'm a registered dietitian. I've worked in the area of nephrology for 33 years now. I've worked with all modalities and stages of the chronic kidney disease. And like everyone else, I'm so anxious for us to be able to prevent a lot of these things that have been happening. So thank you for including me.
Thanks, Janelle. And Maria, would you like to go next?
Hi, my name is Maria Rainier. I work with Sanford Health Systems in the Upper Midwest. And I'm the senior director. I actually work mostly with dialysis, but I have also been involved in nephrology care. And this is so timely because this is actual work that we have started down. We started down the path right before COVID hit, so it's gotten delayed. And in the last 3 months, we've been working on pulling data within our organization and having our data analytics team looking at that information. And so one of our next steps is actually starting to identify some of the gaps that we have in early detection and possibly even in, well, we have to detect it before you can treat, of course. So what kind of, early detection can we have, especially in our primary care clinics and those types of things. So it's very timely work. So I'm anxious to hear what others have learned and what's being done out in the community as well. So thank you for letting me join.
Oh, no problem. We are happy to have you join, Maria. So Jennifer, would you like to go next? Jennifer, I think you're still muted, Jennifer. And Jennifer, if you're having if it's having problems unmuting, if you want to type in chat your responses, that's okay. I'm going to go to Patrick next.
Hello, my name is Patrick Bannon. I'm the regional manager for Avera Dialysis on Sioux Falls, South Dakota. I believe the earlier that we can get to these people and, like you said, detect it early, and the early education, I think, is the best. I like the term that someone said, the softer landing for when they do arrive at the hospitals. So it's not such a life-shattering or life event that they have to go through. So anxious to see what we can learn.
I'm just gonna swing back to Jennifer. Were you able to unmute? Or did I even lose Jennifer totally? We might have. So, and I'll just, Mary, did Jennifer put anything in chat related to her
No, not at this time.
Okay.
I'll watch for her. Maybe she's going to just reconnect.
Okay, sounds good. I'm going to get started. Did I miss anybody I should ask first?
don't think
We are going,
so.
yeah. We will get going then. We have a lot to cover today. Actually, we have a lot to cover every week. So happy to have all of you here with us today. I wanted to start out a little bit just talking about what a structured collaborative is and just kind of give a little background on that for all of you. I'm not sure if everybody's been part of structured collaboratives before, and just kind of talk about what the format will be for each of our 6 sessions when we're meeting. So you have a little bit of idea about that. And then I'm also going to just put the collaborative schedule up there again, just to kind of remind everybody. And I did just want to, I kind of thought about this. I didn't put a slide in, but as we were doing introductions, so Superior Health Quality Alliance is actually made up of 8 organizations. The QIOs from the states of Minnesota, Michigan, and Wisconsin. So Stratus Health in Minnesota, Michigan is MPRO, and Wisconsin is Metastar. The Midwest Kidney Network, which is in Minnesota, Michigan, Wisconsin, and North and South Dakota. And then the hospital associations from the states of Minnesota, Wisconsin, Michigan, and Illinois. So that's the organizations that are part of Superior Health Quality Alliance who is putting on these sessions. So just thought, didn't put a slide in about it, but just would give a little, let you know who we are for those of you who may not be totally familiar with Superior Health yet. So again, what is a structured collaborative? It's really just a framework that we'll be using to help guide our discussion and our outcomes. So the goal is to really have, those same participants on each of the 6 sessions that we'll be talking through, so that, you get to know each other, you're comfortable, sharing things that, you're working on, or, and just kind of working through this as a group. It's not like webinars where you bring in different people every day or every session or that. We're really trying to, get to having the same people on the session. So that's why we had you sign up for all 6 sessions when you registered. I'm not saying we might not have other people join us for session 2 that maybe couldn't make it to session 1, but the real goal is to make sure that you're at all 6 sessions. For a collaborative, usually it's scheduled over a specific period of time, which ours is for the next 6 weeks. And it's really just, again, working on those same goals that all of you mentioned. Each week, our format that we'll be using is, having that welcome. We'll be doing what we call a round robin. That was easy for me to say, excuse me. And again, it's kind of just a check-in at the end of every session. Beginning today, we'll be giving you, we call it the action plan, but really it's the activity that we would like you to work on over the next week before the next session. So I hate to use the word homework. It's more of an activity to take what you learned from today's session and work on between now and session 2. And then we'll do that with each session. And then we'll just have everybody kind of share at the start when we, each session, how that went, what you might have learned. And maybe you learned that what we asked you to do just didn't work in your setting, and that's fine to say. We're also going to start with a polling question. And it's just, again, kind of, there's no, I don't want you to feel like it's a test or anything. It's more of just kind of getting a gauge of where people are for that content that we'll be talking about for that week. Then we'll have the didactic presentation, which is really kind of the meat of what you've probably come here for to learn about. Time for Q&A and discussion at the end. And then, as I said, the very last thing is we'll give you that kind of activity or action that we want you to work on for the next week. And here's our schedule. You probably all have gotten this. And I did send out the slide deck just prior to today's session. So you should have gotten all the slides for today, but just wanted to give you, again, the posting of when we're meeting each week, and then a little bit more about what each session will be about each week. So hopefully that's helpful for you. And then our objectives for today, we're going to really get started with just defining what chronic kidney disease is, describe who should be screened for chronic kidney disease, and then explain the risk factors for progression of chronic kidney disease. And so our polling question for today is, if you could just type your answers in chat, can you identify 2 modifiable risk factors and 2 non-modifiable risk factors for the development of chronic kidney disease? And Mary, if you can just let me know what you're seeing in chat.
Nothing so far.
Okay. And you know what? We do have a lot to cover today. So again, if people kind of want to think on that question, we'll put that question in chat and then people can just start putting their answers in. It looks like, did we get an answer in chat there, Mary?
Yeah, we did. Hypertension and diabetes.
Very good. And yeah, Mary, if you just want to put the question in chat and then people can kind of answer as we move through the discussion today too. Okay. With that, I am going to turn it over to Rachel to do our presentation for today.
Okay, great. Thanks, Jerry. Before we get right to the definition of chronic kidney disease, I wanted to start with the prevalence of CKD. And I think everybody, it sounds like everybody who's here today I'll interchange, CKD is chronic kidney disease. I think we all kind of are familiar with that. But so I just wanted to set that out. But I think it's really important to understand the prevalence of chronic kidney disease because CKD is common, particularly as people age. And I think as Dr. Campbell mentioned earlier, the financial burden as well as the comorbid and mortality burdens of CKD are really significant. So this data comes from the U.S. renal data systems, and about 1 in 7 adults have CKD. That is 15% of the U.S. adults, or 37 million people. And the really big thing about that is as many as 5 of 6 adults with moderately reduced kidney function, that would be stage 3 CKD, don't have a clue that they have it. More than 600,000 Americans have kidney failure. Of these, 468,000 individuals are on dialysis, and roughly 190,000 live with functioning kidney transplant. Diabetes and hypertension are the most common causes of chronic kidney disease. One thing to note is that the percentage of the population with CKD has been relatively stable. And the relative number of people with CKD is small compared to those, say, with like heart disease or diabetes, but the cost and resource utilization from CKD is huge. Okay, next slide. Here we're looking at hospitalization rates with CKD. And this is looking at events per 1,000 person years. And you can see that as CKD progresses, as you move from the far left to the right, the rates of hospitalizations increase significantly. And you can see that the hospitalization rate for those with CKD stages 4 to 5 that are on the far right is 3 times that of the rate for people without CKD. And then overall observation stays shown in red make up about 15% of the combined total and are also higher for CKD compared to those without CKD. Next slide. Here we're looking at mortality rates with CKD. Again, this is events per 1,000 person years. And on the far left column are those with no CKD. And again, as you move to the right, as CKD severity progresses, you see much higher rates of mortality. And again, when you get to stage 4 and 5 CKD, the mortality rate is about 3 times higher than those without CKD. Overall, the mortality with CKD has improved by about 20% over the past decade. So we are doing a better job in caring for individuals with CKD. Next slide. Here we're looking at the comorbidity burden in CKD. And this, we're looking specifically at diabetes, heart failure, and atherosclerotic disease. This data comes from NHANES, which is the National Health and Nutrition Examination Survey. They survey the general population. So this data is a cross-section of the general population of the US. And you can see that in the CKD population, 70% of those people have at least one comorbidity, whereas only 30% of people without CKD have at least one of these comorbidities. Next slide. And then cardiovascular risk and CKD. Cardiovascular disease increases with CKD progression. And so the worse your kidney disease, you have much more cardiovascular disease, which is exactly what this slide is showing. There's increased cardiovascular risk, especially with a GFR less than about 30. But even in earlier stages of CKD, it's not good. Albuminuria is also a strong predictor of cardiovascular disease and all-cause mortality. So, you know, if you add GFR, which is glomerular filtration rate, and we're going to get into that shortly, and albuminuria, you get a very strong predictor of cardiovascular disease. Cardiovascular mortality. Next slide.
Rachel, we have a quick question. As we're looking at this, does that reflect any stage of CKD? Yes,
all stages of CKD increase cardiovascular risk from mortality. As it goes, obviously the stages go up, your risk goes up, but for cardiovascular mortality. But yeah, any stage of CKD, your risk for cardiovascular disease increases. Did I answer the question?
I think you can keep going.
Okay.
Thank you.
Yeah.
Okay.
Yes,
we can come back to it too.
Yeah.
The cost of CKD is huge. $84 billion a year is the cost of care for CKD, not including end-stage kidney disease. $36.6 billion per year, the cost of care of end-stage kidney disease. And really the big number here is of the 36.6 billion per year on end-stage kidney disease, it's only 1% of the Medicare population, but it takes up 7% of the overall annual Medicare spending. So only 1% of Medicare population has kidney failure, but they consume 7 times more healthcare resources than they represent in numbers. And obviously, the cost increases with worsening kidney function. Next slide. So what is chronic kidney disease? The definition from the Kidney Disease Improving Global Outcomes defines CKD as abnormalities of kidney structure or function present for greater than 3 months and requires one of the 2 criteria: either a glomerular filtration rate, or GFR, less than 60 mLs per minute per 1.73 meters squared, and that's in a body surface, and that's used in the calculation for the GFR, or markers of kidney damage, including albuminuria, histology, or imaging. And just to make a quick note, so when I refer to GFR in this setting, we're talking about in the screening for GFR, it's assume that we're talking about an estimated GFR, that this is a calculation, not a direct measurement. So if I say eGFR or GFR, I'm referring to the estimated GFR that's used by calculation, not an actual measurement. This is a nifty chart here that looks at prognosis, not just the definition, but prognosis of CKD by GFR and albuminuria. And what's really important here is that the definition acknowledges that it doesn't just matter whether you have kidney disease or really even what stage you have, but what's the risk of that getting worse and leading to harm. And that's what the classification of staging does. It tells you who you need to worry about and who you don't. So for example, looking at this chart, the GFR is on the left-hand side, and then albuminuria goes across the top as a subclassification. So for example, if you have an individual who has a GFR of say 66, but little or no albuminuria, this is not somebody you have to worry about like somebody that say had the same GFR of 66, but now moving to the right has a lot of albuminuria, or if they have over, if they're spilling over 300 milligrams of albuminuria, that's probably somebody you're going to want to refer to nephrology. So you can see by the chart how the risk of progression increases significantly, not just by GFR, but also by increasing albuminuria. And so what exactly is GFR? How is it calculated? And what's albuminuria? And so we're going to talk about those next. Next slide. So what is creatinine and why is it used in calculating the GFR? Creatinine comes from breakdown of skeletal muscle and also from dietary meat intake. It's released into the blood at a relatively constant rate, and that is in stable kidney function, which makes it an ideal substance for measuring kidney filtration. Part of the issue and interpretation of GFR, which we'll get into, I think, more in session 2, but creatinine has limitations because it varies in production and elimination. So it's not by itself an ideal way to monitor kidney disease, because it's not good for people that have big variations like in muscle mass, like for if somebody's cachectic or they have had an amputation. And there's even certain medications that will change the creatinine without necessarily actually changing the GFR. Some of those, I won't get into a lot of those, but a couple would be aminoglycoside antibiotics. I think trimethoprim can do it. And so those are examples. Next slide. So GFR is an estimated measure of the number of functioning nephrons, which are the filtering units of the kidney. You get an automated reporting of GFR whenever you check a creatinine. There may be labs out there that don't do it. I think probably every lab, most labs in the country do it. But if the GFR is not available from your lab, there are online calculators that can be used. The calculations use creatinine, and they also use age, sex, body size, and race. And I'll come back to race as being crossed out in a second. I'll get through the rest of the slide and we'll talk about that. But a normal functioning kidney filters approximately 180 liters per day, or about 125 mLs per minute of plasma. And for normal GFR in young people starting out is about 130 mLs per minute for men and about 120 mLs per minute in women. And this, obviously can vary in individuals, and over time as we age, that drops. So let's go back to the race being crossed off, and here's why that race is no longer being used in the equations for calculating the GFR. The chronic kidney disease epidemiology equation, the CKD epi equation, that was published in 2009, and it's been widely used ever since then, includes a race modifier for African-American individuals. And so based on the original equation, it adjusts for race because there were some small studies from a long time ago that suggested that African-American individuals had potentially higher muscle mass, and we should account for it. But more recently, the 2009 CKD epi equation was found to overestimate GFR in African-American individuals, leading to differences in clinical care, like delayed referral to transplant when the GFR was actually lower. So in September of this year, a joint task force of the National Kidney Foundation and the American Society of Nephrology recommended adoption of a new 2021 CKD epi creatinine GFR equation that's been retooled to estimate kidney function without a race variable. And so we'll talk more specifically about that equation and the other equations that are still, some are still in use in session 2 when we talk about testing for CKD. Next slide. So, we've established that serum creatinine is used to calculate the GFR, but alone, it's not the best way to detect kidney disease, especially in the earlier stages, not just because of variability in muscle mass and things like that, but also because a rise in the blood creatinine levels is observed only after significant loss of functioning nephrons. Next slide. And so this is an example that we're going to look at that shows you how much the change in GFR changes with changes in creatinine. So if we start, so this is, and I apologize, so the female on the left is an 80-year-old female, and the male on the right is 40 years old. So there's a pretty, so they're very different people. But if we move starting from left to right on the top column there, the top row. If we look at the female with a creatinine of 1, her GFR estimates at 61 mLs per minute. And if you look at the 40-year-old male with the same creatinine of 1, his GFR estimates at 98. So you can see there's a pretty big difference in GFR. And then if you move down to going back to the female, if you look at the creatinine of 1.4, so it doesn't seem like a big change. You've gone from only 1 to 1.4, but if you look at the change in GFR, you've now gone from 61 to 38 mLs per minute, which is almost 50% drop. Same for the male. If you go from a creatinine of 1 to 1.4, the GFR goes from 98 to 65. Obviously, he's starting out with higher GFR, so it's it's still a large change in GFR with a small change of creatinine, but it's not as large as the older female. But when we get into later stages of kidney disease, you can see that by the time the creatinine is 3 for the female, the GFR is already down to 15. And when you go to 3, from a creatinine of 3 to 4, it's a pretty big jump. But by the time you're already that low in GFR, the actual change in GFR is not that much. She's gone from 15 to 11. And same with the younger male. A creatinine from 3 to 4, the change from 26 to 18 in the GFR is not that significant, because by the time your creatinine is that high, your GFR is that low, you've already lost most of your kidney function. Okay, next slide. And I just included this. This is actually a graph of one of our dialysis patients, but it's a graph of this patient's GFR. And I just put this in to make a couple of points. As you can see, this was a pretty steady decline in GFR over time, and I think it goes from about it starts at around 2010, and by the time, so 7 years later, I think around 2017, this person's approaching dialysis. And while this was a pretty steep decline, you can see that if you were just looking at creatinine, I don't think, it's not easy to pick this up. And, when I, in clinic, it wasn't uncommon to hear when you would ask a patient, how do you understand about your kidney disease? We often hear, my doctor says my creatinine is stable. But when we actually graphed out their GFR, it wasn't uncommon to see a picture like this, when in reality, the creatinine really wasn't stable. So you have to be looking at GFR, and also just graphing out the GFR over time is a really good way to monitor what's going on with the patient's kidney function. Okay, next slide. So albuminuria, this is presence of albumin, which is a protein in the urine. It's often the earliest sign of kidney damage. It's a risk of progression of chronic kidney disease, and it's also an independent predictor for all-cause mortality. And there is a difference between when we say albuminuria and proteinuria. For today, we're sticking just with albuminuria, but we'll talk about the differences between albuminuria and proteinuria in the next session. Next slide. So other markers of kidney damage. There are structural abnormalities on imaging that would say be on an ultrasound, that you could see things like polycystic kidney disease or multiple kidney stones. There's obviously histologic changes that would be on a kidney biopsy. And there are electrolyte abnormalities. So the other markers, this refers to, say, if you had a normal GFR and you would end up getting an ultrasound that showed polycystic kidney disease, or say if you had somebody with persistent hematuria and they have a normal GFR, but you end up, and you've ruled out other causes, you end up getting a kidney biopsy, and then you see, cellular damage. Electrolyte abnormalities are in here. It's not common that you would see a normal GFR and electrolyte abnormalities. But it can happen, and that's not something that's going to come up commonly. This would, as an example, I just mentioned that you might see somebody, you have a patient like with persistent hypokalemia or low serum potassium, but a normal GFR. And that might be a situation where you have like a distal or proximal renal tubular acidosis. But that again that's not really something that we're just basic screening for. That's something that you would be referring to a nephrologist for. Next slide. And then who to screen for and who's at risk for CKD. There's a lot on this slide, and we'll go through them pretty quickly, but the big players here are folks with diabetes and hypertension. Those are the two most common risk factors for CKD. After that, I think, there's a lot of other ones. These folks need to be on our radar. People with cardiovascular disease or heart failure, people who are taking frequent non-steroidal anti-inflammatory drugs. Lithium is a known drug that's toxic to kidneys. Obviously, people have a history of acute kidney injury. That's a risk for worsening kidney disease or development of chronic kidney disease. Obesity, family history of chronic kidney disease, age is a risk factor, and then ethnicity and race. African Americans, Hispanics, Asian Pacific Islanders, and American Indians all have higher risk for chronic kidney disease. Autoimmune diseases, urinary tract obstruction, recurrent kidney stones, frequent urinary tract infections, some malignancies, in particular, things like multiple myeloma. People can develop a myelopathy, a myeloma nephropathy. Infections like HIV, hepatitis B or C, sickle cell trait and disease. Another severe COVID-19 has really become a big player in risk for CKD, and IV drug users, and then disadvantaged socioeconomic status is a risk factor. Also, known correlations with CKD are low income, low education, and also those with reduced access to healthcare. One thing I don't have on this slide that folks may be wondering about is a nephrectomy. So I just wanted to mention nephrectomy in and of itself. So if somebody has a nephrectomy, they say they give donate a kidney, or for whatever reason they have had a nephrectomy. That in itself is not a risk factor for CKD, but say you have somebody that's had a nephrectomy that now has later developed diabetes or other risk factors, then that can become a risk factor for CKD. Next slide. And then we also want to just mention that these are important factors in risk for CKD, delivering culturally competent healthcare. So we just want to make sure folks need to be cognizant of cultural needs like diet, religion, social needs like food and pharmacy deserts and trust issues. And then there's linguistic needs as well that you need to be cognizant of with language barriers. And then lastly, prescribing patterns. We put this in there because we want to make sure that folks are prescribing ACE inhibitors and ARBs for African Americans with diabetes who have hypertension and albuminuria. And we put this in because years ago, there were some studies that suggested that African American individuals didn't get the same benefit from ACE inhibitors or ARBs as non-African Americans did for the treatment of hypertension. So they weren't getting these medications when they had hypertension and or diabetes and albuminuria. But newer evidence doesn't support that claim, and so the standard of care is for anybody with diabetes, hypertension, and albuminuria to be getting these medications regardless of race. Next slide. And then finally, we're going to look at risk factors for progression of CKD. We've talked already about albuminuria. This is a very big risk factor. And then for those folks that have a lot of albuminuria, in and of itself is an independent risk factor for disease progression. Hypertension is also a risk factor for disease progression. And I just put this, one size does not fit all. And we'll, I think in session 3 in particular, Dr. Siegel will talk more about hypertension targets. There's a lot of different targets out there, and particularly in folks with CKD, one size does not fit all. So he'll be addressing that in session 3. Poorly controlled diabetes is a risk factor. Acute kidney injury is a risk factor for progression. And there are some genetics that also predispose for progression of CKD, and that would be some forms of polycystic kidney disease. And then lifestyle risk factors, particularly smoking and obesity. And then finally, metabolic acidosis is also a risk factor for progression of CKD. Next slide. I think that's That's it.
Yep. So that's the end of our, thank you, Rachel. It's a great presentation. So the end of our formal presentation. So I'm going to check in with Mary now. It looks like we had a lot of activity in chat. Do we have some questions there for Rachel or comments to share?
I do. Just quickly, though, I want to welcome Candace Coles. Candace, if you'd like to put in the chat the organization you are from, as well as your position, and also what brought you to us, being a part of this group. And then I wanted to go back. So again, welcome Candace. But then I also wanted to just double check that Maria had her answer or got her answer she was looking for. I know that she was actually speaking about a slide prior, which was back a bit, but then I think Dr. Campbell may have answered your question, Maria. So pipe up there, rechat or open your mic to let us know if we've covered it for you.
I think I was looking more at when you were presenting the costs right before that slide that we kind of answered that questions from. You know, does that include all stages 1 through 5?
Thank you
The
for
one
that.
right behind that.
On the
One more
cost of
forward?
CKD. Yeah, I believe, yeah, sorry. I do believe that includes all stages, excluding end stage kidney disease.
Okay.
Yeah.
Because I know the NKF gave us some very specific numbers in terms of, you know, they actually have it assessed by stage. It's something that came from the American Journal of Managed Care in 2017, so they're probably a little bit behind. But I mean, it's very interesting because even in stage 2, which you think that's a very silent stage, because you know there's no symptoms to really speak of. I mean, that level of CKD out and 2017 costs us around $17,000 a year per patient.
Yeah.
So I mean, I think it's very interesting to start looking at some of these. I mean, I think we understand the total cost, but when you start looking at it by stage, and then I mean, it doubles once you hit stage 3.
And let me say, there are so many confounding variables because it's hard to tell sometimes which is the chicken and which is the egg, because a lot of individuals are in stage 2 because of so many reasons, and it becomes chronic. It could be an acute insult, sort of like a motor vehicle accident where they actually became hypotensive, lost a lot of blood, and then they develop chronic kidney disease. Or it could be infection, such as in a child with a strep throat. So it's hard to extract the data in a very pure form. It's a little bit easier as you get down through the stages like 3, 4, and 5. Certainly, it's a lot easier for ESRD on dialysis. In corrections, while I was with Centurion, I did a study on our 40 correctional patients. These are prison patients. And just looking at ESRD costs, not hospitalizations unrelated to ESRD costs. Those are like going in for surgery, shunts, and so on. Costs us $3.4 million a year for 40 patients. We didn't even touch the other stages. This is just ESRD. On average, it may cost about $400,000 comprehensively for treatments and hospitalizations, outpatient issues to take care of for ESRD patients. So very expensive. And the last thing I'll say, 80% of patients that come to dialysis have vascular calcification in their aorta, significant. And it extrapolates to their coronary arteries too. So it just doesn't happen when you come to ESRD. It's built in from stage 1, 2, 3. And that's why we say at every stage, there's increased costs, there's increased cardiovascular risk which contributes to morbidity and mortality. But excellent presentation, Rachel. Wow,
Yeah.
very good.
Thank you.
And then Maria, you did have one other question in the chat. And Dr. Campbell did mention about that. We will be looking more into that next week, but did you have any follow-up question or need for answer this week?
No, I unfortunately, I'm not going to be able to be here next week because I have a conflict, but I'm hoping to get more understanding of utilization of one versus the other.
Great. And we can feel free to also, if you have some additional questions around the area for next week, feel free to send them to Jerry and we can make sure that they get answered, during the session. And then of course we will be recording that session as well. So you'll be able to catch up.
May I say one more thing else, Rachel, if you don't mind?
Sure.
One of the things that we're concerned with as individuals that are in the CKD arena, you look at the lab reference range and the hospital reference range for GFR, they give the false impression that if your GFR is over 60, it's okay. There's no red flag. And that's been a fight that I've been fighting for years. I'm glad they start to put a red flag, but it should not be at GFR over 60. So you could actually lose over 40% of your kidney function before it's flagged. And my brother is primary care and pulmonary, and nothing is more annoying to him than someone seeing someone else for years and telling them, well, your GFR is over 60, you have no problem. And then it's 59, and here comes another doctor telling you, oh, by the way, you've lost pretty much half of your kidney function. And well, what happened? So I think we need to replace that with the actual eGFR, like some places do, some hospitals, some labs. And this is where we all can participate by putting pressure on the hospital labs and the major labs to actually render an exact eGFR rather than just saying greater than 60.
Right, you're absolutely right, and that the just reporting the above or below, or rather below, less than 60, that's the MDRD equation, and I know a lot of labs have moved away from that, so we do have that 2009 CKD EPI equation, which actually does report out the exact GFR, whether it's even if it's above 60. And then I think all I know is I've been told, like for U of M, for us, starting in January, we're going to be replacing that with the 2021 CKD EPI equation, which will then eliminate the race modifier. But, that's, you're right. And also in reporting out an exact number, that's where it's going to get, it's going to be more important for primary care providers to be able to interpret whether that number, because we're going to be seeing larger numbers. And so there's going to be, it's going to be more important to be able to interpret whether that person actually has CKD, and I know that, that you and I know Dr. Siegel can address this in the session 3, but, I'll just give you an example. I just had my labs done, and I'm almost 59, and my GFR I was reported as 75, and so technically you could look at the graph and go, wow, I have CKD, except but I don't have any other risk factors for it. So I'm not hypertensive. I don't have diabetes. I don't have any albuminuria. So no, I don't have. I'm somebody that I don't have CKD. But it's going to be more important to interpret and to do more testing of people that kind of fall in that gray area. That say somebody is 70 years old and they have that GFR of 66, but they are hypertensive and you haven't checked the urine. It's probably time to check a urine to look for albuminuria. So there's going to be more need for more careful interpretation as well.
I just want to check. Go ahead, Maria. I was going to say we're getting to the point where we need to wrap up questions here, but did you have a question, Maria?
I was just going to ask, has there been any research done that has looked at actually, you had talked about having graphing it out, that GFR level out and watching that. Has there been any research done that shows a percent of change in the GFR would equate with the amount of time or the level of progression of the kidney disease that can associate, this much of a drop in GFR in 12 months would equate to, they're going to be in end stage by year, 2 years from now, or whatever it might be.
Yeah, that's a really good question. It's really still hard. It's very hard to predict how people progress. I mean, we know there's modifiable risk factors that we can slow things down. There are some people, despite controlling their high blood pressure and their diabetes, they still have rapid progression for not clear reasons. But what we we have a lot of data from our clinic that I don't know that we've looked at this specifically yet, but how, looking at does graphing GFR out and following it that way, do people have actually better outcomes, and do we slow the progression? Do we do a better job of slowing progression? I think we do. I think just observationally, I can say that, we got folks referred to us to our CKD clinic that were had progressed pretty rapidly down to about, a GFR of 20, 25. And we've had kept patients off of dialysis for, 5, 6, 7 years with that low of a GFR.
Let me say this. There's a quick question about checking BUN to creatinine ratio. Does it compare to GFR? It really doesn't, because the BUN to creatinine ratio can be affected by so many things, such as hydration, such as nutrition status. It's just not as reliable as GFR. And certainly just a random creatinine is not as useful as an eGFR. That's my takeaway from the question, if I answered correctly. Mm-hmm.
And I just want to check to make sure there's not any other questions, Mary, in chat that need to be answered, or any other questions. Dr.
Campbell caught that one. That's great. And Deb, if you have any follow-up questions, please place them in the chat or open your mic. Or you can also email us in between our sessions.
So I just kind of, because I'm all about the action plan here. You guys probably saw me all bringing up the action plan. What I had mentioned when we started our session today is that the action plan is really that activity we'd like everybody to kind of, to use what you've learned today to start, putting this into practice in your setting. So our question for next week, versus using the word homework, is if you could work on differentiating those patients who are at high risk of progression of CKD versus those who are not at high risk for progression of CKD. So that's kind of the activity we'd like you to work on over the next week at your organizations or facilities. Don't feel like you have to come back to us with a number or anything. It's more, was this something you were able to do? Was this easy to pull? Was this data easy to find? I mean, certainly fine if you want to share numbers with us, but it's more about, was this something that you could do, an activity you could continue to do too, to keep track of those patients who are at high risk, so that you can monitor them and keep an eye on them. I also just wanted to say quickly too, I know Maria, you said you won't be able to be here next week. I want everybody, like Maria or any of the people here today, if you want to invite other team members from your facility to join us on these sessions, please feel free to do so, because we know everybody kind of works in teams. And so feel free to invite others to join us for the upcoming sessions. What I'll be doing after this session is I will send you, I know I sent this PDF of the slides out prior, but I think there was a slide missing. So I will resend the PDF. And then too, if you have any further questions, you can either put them in chat and we'll make sure we get them answered, or you can email them to me. My email address is jhenniker@stratushealth.org. I don't know, Mary, if you could put that in chat quick before we close out here. Otherwise, I'm sure you probably all know. I think you all got an email from me anyway, so you probably know how to get a hold of me. So,
when you send out the slide deck, do you want to just put it on this action plan page?
sure. Yep. You know what? Actually, what we'll do from now on is we'll make sure we have a closing slide with a contact info. Thanks, Maria. That's a great suggestion. I'll make sure we have a contact slide there.
And
Anything?
this is Diane. Can I add one thing
Sure.
also? Years ago, when we were doing some work with nephrologists about chronic kidney disease, we asked them, do you reach out to your primary care group? You know who your referrals are. Do you refer and do you educate and do you involve them? Do you share resources? And they said, oh, yes, we do. And we said, well, what's the frequency for that? Because I know that Sanford and Avera, you have your energies in both camps, the end-stage renal disease camp and the CKD camp. But the challenge of their answer was they said, oh, yes, we do. We do it at least once a year or once every 2 years. And I think at that time, I'm still frustrated that this is ongoing. Rachel and Dr. Campbell, this was wonderful presentation. You're telling us of things that have just happened recently. It doesn't help to just inform primary care physicians that you did it in 2016 or 3 years ago. So I really thank everybody for being on this call and sharing what you're learning with your primary care referrals within your healthcare systems. Thank you so much. This is really important work.
And I will let you all go now. I know we've held you here a little extra. I appreciate your participation and thank you. We will see you all again next week when we'll hear from Dr. Campbell. Bye, guys.